Okay, great. Thank you so much, Bob. So coming back, I think someone was asking from Matt, could you explain the cervical application? So cervically, obviously, we can do foraminotomies from the back as well, and that's very similar to lumbar foraminotomies. You have to use you have to be very careful because it's obviously a much tighter area. But also from a standard ACDF, we have these type of devices that are shielded at the foot, and you can see that right here. They're foot shielded devices, and I'm holding one in my hand right now, if you can kind of see that, that are really optimally designed to come down, as you can see in this video, come down this space, and then work around the corner to take apart those osteophytes that can often be very difficult. So, you know, how, like the ACDF, we often will take those marginal osteophytes with a combination of, again, drilling and kerrisoning underneath the edge. But this is nice because it allows you to do a real angular cut, as you can see in the video where I'm demonstrating here with the side cutting device, to remove those osteophytes and make sure that the dura is completely decompressed without having to slide big kerrisons and things under there. And here, there's a much longer upcutting version, and that can be used once you've created a partial cut of the osteophyte, and you can get another tool, and then you get the curved upcutting tool, and you can actually perform an undercutting corpectomy, or like a much longer partial posterior corpectomy to decompress the cervical spinal cord or the thecal sac in an A-lift. And so that's the cervical application. Standard foraminotomy using the upcutting bits, and then undercutting osteophytes of the dorsal disc space, and even some of the bone in cases like that, as you can see in this graphic right here as well. So these are all techniques that can be done with that, and I'll show you some of that. So this concept of using it to remove anterior bone osteophytes here at this space right here is something that, for example, Dr. Ashkenazi Ali and Dr. Geyer and Harrell and some of the other people have used to remove osteophytes that you would have otherwise had to do a full corpectomy to remove. And so these are 30 patients where they did just that. They were able to gain access to osteophytes in adjacent vertebrae, eliminating the need to do a full corpectomy, if you will. So from one ACDF or one corpectomy approach, you can do the next level's ACDF decompression as well. And you can see the outcomes of that, the fact that the decompression was adequate, was good, and was effective in relieving the radicular symptoms. Here's an example you can see on the MRI, 69-year-old male with severe myelopathy from what's called the segmental OPLL type thickening and osteophytes. And you can see what they did was they did a one-level corpectomy, which means 2, 3, 4, 5, a C5 corpectomy. And from the C5 corpectomy, they reached around and they decompressed all the elements behind the C6 body and down to that. And then they did an ACDF underneath the C6 body. So they were able to undercut it and preserve the C6 body and not have to do a full C6 corpectomy. In other words, they got all the bony compression, but managed to save a good portion of the load-bearing portion of the C6 vertebral body and allow you to do a short corpectomy cage and an ACDF cage with 3-point fixation, which obviously biomechanically is much better than a long corpectomy cage in terms of rotation, inflection, extension, stability. So you can see the arrow pointing out where they had reached under and cut out that central calcified PLL ligament, and how they did a very nice job with that. So multi-level compression, saving bony attachment points, saving vertebral bodies. That's another benefit of the extended cervical applications of these tools. And there you can see an intraoperative video or lateral fluoroscopy showing how he's reached the curved tool through the corpectomy defect right here, and we're undercutting the posterior aspect of the cervical C6 vertebral body. But you see, we're reaching here all the way up to halfway up the vertebral body. So again, you know, sparing the need. In other words, people say, how do you decompress right behind the vertebral body if the PLL is calcified without taking the vertebral body? And this is an alternative right there as well. So again, another case report, oops, sorry. Another case report, again, you see 2, 3, 4, 5. Again, from there, you see these large osteophytes coming off. And then this is much more of a standard ACDF approach. We're always reaching to take down these osteophytes above and below. And again, that tool we mentioned allows you to side cut safely and effectively remove all that osteophyte. Pre and post-operatively, you see the osteophyte's been nicely resected from that perspective. Oh, you're welcome, Matt. Thank you. And so here's another uncinate resection of foraminotomy in a standard ACDF. You can see here, not only can you undercut those bony edge osteophytes, you can also do it kind of sideways and reach into the frame, because sometimes you have these large osteophytes coming off the anterior edge of the vertebral body, pushing in and compressing on the nerves right there in that corner, or like an ACDF right there in that corner in what we would call the for proximal foraminal lateral recess. And again, here you can see on the post-operative CT, they've resected with the side cutting tool, they've resected a portion of the lateral uncus to again ensure that there's no residual compression of the exiting nerve root, which again is something that in a very narrow slot ACDF that we sometimes leave behind, if you will, and leave behind residual compression. And that's where you can see 20 patient case series using we always say we do a central spinal cord decompression, we do bilateral foraminotomies. So this, again, it's an elegant foraminotomy tool that can be used to open up those spaces.